Many thanks for staying with us right here on KBC Channel 1. You're watching Good Morning Kenya. My name is Mike Miguel. If you're just joining us, this is Health Tuesday segment. Happens every Tuesday, and we want to talk about something very important. Now, every day up to now, Kenyan children are diagnosed with cancer. And for most families, those are the news that come way too late, maybe at a stage where treatment is costly, survival rate is low, and also hope fades fast. And you know, a child lingering with a lingering fever, unexplained fatigue, you know, a growing swelling, is some of the risks or the signs that we should be looking out for when it comes to matters that regard childhood cancer. And today we just want to understand childhood cancer and early signs that as a parent you need to be aware of. And Dr. Rose Munge, who is a pediatric oncologist and head of unit at Kenyatta University Referral and Research Hospital, joins me to talk about this topic. Karibu sana.
Asante sana.
How are you doing this morning?
Good. It's a bit cold.
Yeah, today the weather is doing its thing.
Yeah, but it's okay. We thank God for rain.
Yeah. You know, when you mention cancer, in adults, you know, the first thing that comes to mind is the basis of screening. Things like, we are talking like if you smoke a lot. Maybe what you eat. But for children, it's different.
Yes, it is.
So what behaviors put children at risk of cancer? Is there a behavior that puts them in the risk of cancer?
Unfortunately, no. There is not one specific thing that I'll say for most cancers, we cannot identify the exact cause why they got it. Sometimes it's genetic, sometimes it's just a random mutation, but it's very hard to pinpoint, except for specific things. For example, if you are near somewhere where there was radiation, then the chances of cancer increase. But for most, we don't have that. Yeah, so it's a difficult question to answer to many parents when they ask, why did my child get cancer? A lot of the time we will not be able to give you a specific answer as to why. Because
the question maybe a parent would ask, what did I do wrong and what did I not do right?
Usually there is nothing that will tell you concrete, we have connected this to this. Yeah. There are some cases where it's genetic, but sometimes there's nothing you can directly connect and say, this is why you got this cancer.
In cases where it's genetic, what are we dealing with?
Usually it's a mutation, or something is either not working the way it is supposed to be working, or not switching off the thing it's supposed to switch off, so the cells excessively multiply. Yeah.
Now, I want you to talk about how childhood cancers differ from adults, especially in terms of causes and outcomes.
So, first of all, childhood cancers are rare. Okay, if you look at in the grand scheme of things, childhood cancers are rare. They are rare disease. They do happen, but they are rare. The longer you live, the older you are, the higher your chances of getting a cancer. So of course, an adult has a much higher chance of getting cancer than a child. But like I said, sometimes it is that there's a mutation somewhere along your genes, something is not working the way it's supposed to be. Sometimes it is that, so the cells that you have when you're being formed before you are born, those immature cells, some of them don't go away completely. And so when you're born, you're still carrying some of these immature cells, and those then transform to become cancerous. Sometimes it is exposure to certain things, but those are the minority. Yeah.
And you know, in a country where that records 3,000 to 5,000 cases of childhood cancer, You know, why do we still have low awareness in terms of what people know about these cancers?
I think for a long time, people thought children do not get cancer. It was not, you know, if you're looking for something that you don't know what it looks like, you will not see it. So for a long time, people thought children don't get cancer. Again, because of that association of it is your diet, it's the exercise, it's the smoking, it's the drinking. Children don't do those things.
Exactly.
Yeah. So people thought for a long time they don't occur. And childhood cancers really resemble a lot of other very common childhood illnesses. So the first thought for most clinicians, when I see a patient with certain symptoms, the first thought is never cancer. It's always there's something else. Like I said, in the world of childhood illnesses, cancers are not as common.
Yes.
They do occur, but they're not as common. So if the first thought is cancer, then you'd be doing very many tests. You will spend a lot of money trying to look for something that's not there. But we do need people to know, if you see this pattern and you see it once, twice, 3 times, 4 times, you're not getting out of it, then you need to start thinking broader. Yeah.
Now, when you look at it, from what you've said, what are the most common systemic challenges that may lead to low awareness in terms of what people know about childhood cancer? Does misdiagnosis play a part in it?
Yes, it's very big. Like I said, it looks like a lot of things. For example, cancer will come with fever. All childhood cancer illnesses come with fever. So if a child comes in, they have fever, they are not feeding very well, they don't want to play. Ask any mother of a preschool child. When that child has a flu, what do? They have fever, they don't want to play, they don't want to eat. They seem very similar, right? If you have malaria, for example, you have fever, you get pale, so the amount of blood goes down, you're not eating as well, you're vomiting. Childhood cancer has similar symptoms. If you have, for example, abdominal swelling, there are a number of times someone will say, oh, the child has eaten too much, that is constipation. They are not going to the toilet the way they should be. By the time you realize that this is not going away, they have been treated for other things as you're trying to figure out what is best for the child. So it is missed quite a lot, and that's part of what we are trying to now educate. If you see this pattern of symptoms, the mother, take the child to hospital. If you do not get response, the treatment doesn't work, go back. The healthcare workers were also having the same conversations. If you see this, of course, this pattern, a lot of the time it will be an infection. But if you've treated it and it's not going away, don't change to, now let me give stronger antibiotics. And then the third time, you can't have malaria for 4 months. You understand? Yeah. And so sometimes also where we go wrong is you change facilities. You go to this person, they treat this. That doesn't get better. You go to the next different person, don't tell them about what has happened, you get this treatment. Go to a different facility. By the time all those things are linked, you've wasted time.
You go to the doctor, another doctor, you do not give a history of what you've been.
Yes, a lot of patients.
So in other words, you're seeking another doctor's opinion
without
giving
full
background.
Picture. Yes.
Which is very dangerous.
Yes.
Do we really have national screening cancer, screening for children?
We don't screen for children. Apart from the cancer of the eye, called retinoblastoma, which is usually screened when you go for the well child visit. They will shine a torch into the baby's eyes, and if there's a certain way it is supposed to look, and if it doesn't look, then that is considered a screening. But for all the others, there's no screening test. There's no screening test.
That could be where we are failing as a country in terms of dealing with.
It's not a failure as a country, because the way they present, there's nothing to screen. They either start developing the symptoms and you catch it early, or you find it, a lot of, like the abdominal tumors, a lot of them are coincidental. A mother is washing a baby and notices, oh, there's something here that is strange. Now that, you should go to hospital. Because if you say, let's wait and see, 3 months down the line, that has become bigger, it is harder to treat. Yeah. So but a specific screening test, apart from retinoblastoma, is not there.
What kind of childhood cancers are common amongst children?
Leukemias are high on the list. That's blood cancer. And that is worldwide. That our trends are similar to what we see out there. Quite high on the list as well is brain tumors. Okay. Then we have the solid organ tumors, the one for the kidneys, the liver, the muscles. In teenagers, we see a lot of bone tumors as well. Then now the other organs come in less. The majority is leukemias, blood cancers. After that, brain tumors. Then after that, we see the kidneys, the liver, the muscle, the bone. They all come down. Any tissue in the body can become cancerous. It's just that the pattern that we see, these are the most common compared to this one. But you can have a cancer of any part of the body.
Are the signs the same? Like, let's say if you're having, if the child is having leukemia, what signs should a parent be looking out for? The most common and noticeable signs.
So leukemias, a lot of the patients will, and I'm not giving this in any particular order.
Yes.
But there are some who will complain of they're tired because the blood level goes down, so the activity levels are lower. So you'll notice that the child is not as active as they were before. If you look at the color of the hands, the eyes, they look whiter than they were before. You will see sometimes swelling. You know, these lymph nodes along here, what we call in my language, guy.
Yes, yes, yes.
So you have them here, you have them in the axilla, in the armpits, in the legs.
Yes.
Those swellings that they are growing bigger.
And they are very painful.
They may not be painful. They are painful when you have an active infection. So the ones for leukemia may not necessarily be painful. They're just big and you notice that they're growing bigger. You will notice weight loss. The child is just not growing the way they were before. So the weight loss, either they will stop eating as much as they were, or now even if they're eating, it's not, they're not gaining weight. They tend to have sweating, especially at night, fevers with a lot of sweating. What I have just described, very similar to TB. So for a lot of patients, you see how you can very easily confuse the symptoms of leukemia with TB. You have the node swelling, you have the weight loss, you have the night sweats, similar to TB. You can have joint bone pain. The limbs are paining. So the arms, the legs. So the smaller children will just start refusing to walk. The older ones will say, when I walk, I am having pain. Okay. If it gets to a point where the platelets are also low, you start seeing issues with bleeding. So they get spots on the skin, you bruise easily. If you bleed, if you get cut, you bleed a lot longer than before. Or you see these marks under the skin, like you get a bruise, then you bleed under the skin, but it is just progressing. Yeah, so those are some of the signs we see.
Yeah. And how do you know it, as a parent? I'm thinking of a parent in the village right now. At what point do you know it's time to take your child to the doctor?
So most parents can tell when their child is unwell. There's a lot of crying, they're irritable, they don't want to do what they're normally doing, they have these symptoms, the fever, the weight loss, the what. Then you take your child to the hospital. They will do a check, right? And sometimes they will even do a blood test. A lot of the time, it looks similar to what happens when you have an infection. So a lot of the time, you will get an antibiotic and painkillers and told, take this, come and see us in a few days if you don't see response. Now, that's where the the difference is. If it is an infection and you're given medication and it goes away and the child comes back to their normal, happy, usual self, then you're fine. But you've given this medication, you're not really seeing a difference. You go back, have them rescreen again, have them do the test again. That is what will make you think, oh, what is happening? Because usually by the time they are coming to me, they have gone through quite a number of different facilities, different doctors. I'm usually not the first line of seeing these patients. I'm usually the one at the end of that long process of referral. Yeah.
Let's look at the diagnosis process. A parent walks into a hospital today with a suspicion something is wrong with their kid. And this is relating to the childhood cancer. What does the diagnostic journey actually look like step by step?
So that will really depend on which kind of cancer we are talking about.
It's not a one fits all.
No, it's not. For example, if you have a blood cancer, the first step is the blood count. And then if those, depending on how those parameters look, there's an additional count called a peripheral blood. Then we are trying to see between this blood count and what I see. A peripheral blood is you look under the microscope and see, can you see any abnormal cells? Then if you do, then you now add in additional tests. Now I want to see, of these abnormal cells, what exactly are they? So we might need to do something called a bone marrow aspirate, where you go to the bone marrow, take a bit of that, look at that. Then that helps to differentiate for you what different types they are. Now, there are also other tests we do along that to make sure that you're going to be able to take medication if you need to. That's for blood cancers. If it's, for example, an abdominal swelling, by looking, I can't tell because it's inside there. So now I'll need to do some imaging. Okay? So I'll need to ask for an ultrasound. If the ultrasound gives me enough information, well and good. A lot of the time it will not. So I will need to do a further testing. So that means I will need to do a CT scan or an MRI. Now that tells me, okay, the organ that is affected is this one. And given how it behaves, how it's looking, it is likely to be this. So for some, the image alone is enough. For example, the ones for the kidney, there's a way they look that you can look and see this is a kidney tumor and we can start treatment. There are others where you're like, I'm not so certain what this is. You will need to get a biopsy. So you'll bring in a surgeon to go and get a piece of that. That's taken to the lab and it confirms the type of cancer. For bone tumors, you have a swelling, you can see it. You do an X-ray, see how the pattern is, you do a biopsy. So it really depends on what system is affected. If we are suspecting a brain tumor, I must get a CT scan or an MRI. So there's no one size fits all. It depends on which one you're suspecting. Because again, you don't want to just go scanning, testing everything without a focus.
Now, when you look at treatment, you know, there's this perception that once you get cancer, it's a death sentence. How treatable is childhood cancer, especially when it's caught early?
Oh, I love this part. There are some childhood cancers, depending on where you are in the world, that the cure rate is 98%.
98%.
Yes. But again, I want to give a disclaimer that that's not for all cancers. There are certain types that is the number. But you will find in most high-income countries, the cure rates are about 80 to 98%, right? Depending on what it is, the treatment available, all of those things. Now, on our side, where we are, even the ones that have a good chance of cure, we're not getting those numbers as much as we would like to. So for us, we see about 30-40% cure rates. Yeah. And the WHO is trying to move us, like there's an initiative to try and move our cure rates to 60%.
Yes.
So that's the aim. And so that we can narrow this gap. But if a childhood cancer is treated early, is caught early and treated appropriately, there are very good chances of cure. Children tolerate chemotherapy much better than adults.
They have to go through chemotherapy.
Yes, it's part of the treatment. It's part of the treatment. But they do much, much better than a lot of adults, especially if it is caught early. So of course it depends on the location, what exact treatment is needed. But for a good majority of the patients, there is actually cure.
And when you look at the treatment option, you've said chemotherapy. What other options are available in Kenya today, and how accessible are they?
So depending on the type of cancer, there's chemotherapy, there's surgery, there's radiotherapy. So for leukemias, it's mostly chemotherapy. That's what we do. For the solid tumors, and when I say solid, I mean the organs, the muscle, the bone, the kidney, the liver, the brain. Surgery removes most of it, and then you add in your chemotherapy and radiotherapy to support. Depending on the stage, there are some tumors surgery alone is enough. There are others that you do surgery and then you add on radiotherapy. There are others that you do surgery, radiotherapy, chemotherapy. There are others that you do chemotherapy and radiotherapy. So it just depends on which one, and all of these options are available. There's surgery, there's chemotherapy, there's radiotherapy. If you go to a comprehensive cancer center that offers all of these treatments are available. So that those are the 3 national hospitals. There are some private hospitals as well. There are some regional hospitals that will offer part of this. So they'll give surgery and chemotherapy, or they can do radiotherapy. So it depends on which region they are in the country, but they are available. What we are working towards is getting bone marrow transplant services. That one is, there are institutions that are starting that pretty soon. But for the other treatments, they're available in the country.
Can childhood cancer actually be prevented, or the focus is purely on early detection?
Early detection, early cure. Prevention is not really part of the language in most childhood cancers. Yes.
Why?
Because there's no way to screen for them. There's no way to. So, so the thing is, everyone can have a mutation. There are some who will proceed to have the cancer. There are some who won't. You can't predict who will go down which line. Yeah. So we really can't say prevent it. Of course, if you lived next to nuclear reactors, would say, okay, don't leave. Exposure
to radiation.
Yes, or if you're using this harsh chemical, then you want to have full protection and things like that. But most kids don't go through that. Yeah.
Are there support systems that parents should be aware of, especially parents who have kids with cancer?
Yes, so the other thing about childhood cancer is, even if I have in my facility the medication, without the rest of the support, it's very difficult to get good outcomes. Remember, when a child is unwell, the whole family almost is unwell. You can't leave the child alone in hospital. So that means you have to have a caretaker with them almost full time. There is loss of income around that. There is children want to play, children need nutritious food, children need psychosocial support. So all these things come together to help with the treatment of the cancer. You need nutrition. Nutrition is important. If you're malnourished, going through cancer treatment is really tough. So you need the nutritionist on board, and the medications we use really mess with our appetite. So you need the nutritionist on board to make sure you're getting a healthy diet. Sometimes we need, they've done surgeries, they need physiotherapy, occupational therapy, so that they allow for the use of that limb. We need psychosocial support. You cannot treat a child like an adult. They are not small, adults. So you need to put them, you need to give them play therapy. And children are very easy to see when they are doing well, they play. When they are feeling better, they play. When they are not, they are down. So it's one of the ways also we can see, is this child feeling better or not? We add in the play therapy. We need to have psychosocial support for the parents, because a lot of the time the parent is carrying all of this. The child may not understand what exactly is going on, but the parent understands and has to be strong for this child. So you have to have those parental groups, and they are there. So hospitals will offer pastoral support, they'll offer palliative care, they'll offer counseling services, they'll offer play therapy. All of these are part of the treatment of childhood cancer. Yeah.
And when you look at access to financing of childhood cancer, from your perspective, what gaps still exist within that regard?
Treating cancer is expensive. The medications are expensive. Radiotherapy is expensive. The lab work involved to getting the correct diagnosis is expensive.
Yes.
So our national health insurance covers quite a bit. It will cover the drugs, it covers the hospital stay, it covers surgeries, it covers radiotherapy. But all of these covers have a limit. So we are lobbying for expansion of how much this amount is. So that's part of it. Diagnosis plays such a big part. See, if I don't know exactly what I'm dealing with, it's very hard to plan the treatment. And some of these diagnostic tests are not easily available. And when they are, they're not in the public facilities where the insurance covers, where SHA covers. So that means then sometimes patients have to dip into their pockets, because if I am to do it properly, I would need this additional testing. That's a strain for a lot of parents. So we are, and the insurance scheme has been very, they're listening to us, because we tell them we need this for this. We need this test to be covered under. And so there's a lot of adjustments being done. And so we're seeing a lot more being covered under that. So there's hope. So having SHA goes a long way for some of these things. It might not cover everything, but we're working towards it. Yeah.
Now, I'm looking at a person who is at the village. And the first line of defense is primary health care. But here's the reality. A child first presents at a dispensary or health center. How equipped are our frontline clinicians to even suspect it's childhood cancer?
So there are some that are fairly obvious. If there's a swelling somewhere, you suspect it. What we are teaching is do a direct referral. So our hospital system used to be, you go to level 1, you're referred to level 2, you're referred to level 3, then 4, then 5. And that process can take quite a while. So what we are now saying is, if you have any suspicion of a childhood cancer, refer directly to the level 6. Don't do these small steps, just refer directly. So we are having, we have education sessions, seminars where we teach healthcare workers, and we are giving them contacts directly to the specialists, and then they can talk to directly the specialist. For example, I get a call and they say, I have this patient, I'm seeing this. Do you think this is cancer? If I think it is, then I'll tell them send directly to the hospital, and then I can continue my evaluation from there. So we're trying to cut down this step. So the people who we are telling are the healthcare workers, the primary people. If you suspect, if you think it is, you think it, just refer directly. Don't wait to do those steps. Yeah.
And at that point, should childhood cancer training be mandatory at the primary healthcare level? Should it be mandatory so that it can help even in early detection?
There is some form of training that happens for all healthcare workers. But remember, I said it's not common. It's not common. So for 100 children that you will see, it will be 1 or 2 that will probably have cancer. So what happens is, over time, if you're not seeing it, over time some of these things, it needs revision, let's call it that. So what we do is that, have a CME, have a conversation. Every so often, every few months, we are reminding them, because it's also not the most common illness to see. You will see pneumonias, you will see malaria, you will see typhoid, you will see all these other things very many times. By the time you get one who you suspect it is, then that is the one who we're trying to have it in the back of your mind that for this one, I need to urgently refer. Yeah.
What are the most common and difficult side effects that children go through during treatment, and how can parents prepare for them?
So before we start chemotherapy, we have a conversation with the parent and the child, if they're old enough to understand. Now, the things that especially girls bother them the most, the hair falls out. And then their nail changes and skin changes. But what we say is it will fall out and then it will grow back. So that is temporary. The more serious side effects is chemotherapy is pretty strong. It can cause you to vomit when you're taking this medication. We have some medication that helps to reduce that. It will give you the risk of getting infections. So we usually screen, cover you with antibiotics, make sure that you're not, your immunity is not too low to be able to tolerate the medication. So there are certain screens we do. Longer term, there are effects on the kidney, on the heart, on the liver. We check them before you start your treatment, before every cycle of chemotherapy, and as frequently as we need to see if you're able to tolerate. And then depending on what those numbers look like, then we also adjust the medication. Yeah, so it's a back and forth. You tell us, oh, I'm feeling like this, we check, we adjust the medication to sort you out.
And are there long-term effects that children who've survived cancer face, and what should parents be ready for? Talk about those.
So one, again, it depends on the type of cancer.
Yes.
Because the type of cancer dictated the type of treatment you got. So, for example, if you had a bone cancer and you had an amputation, the long-term effect of that is that you have an amputation. So you will need to learn how to use mobility aids.
Yes.
You will need to get maybe a leg or an arm put in. You will need to learn how to do physiotherapy. There are all these different side effects that come with that.
Yes.
Radiotherapy also has longer term effects. Can affect your immunity, can affect fertility. It can predispose you to a second cancer down the road. So you want to also be screening every so often. We come in and we actually look for some of these side effects.
Yes.
If you had a brain tumor, you had brain surgery, sometimes that can affect speech, it can affect vision. So it depends on what cancer it is that you had and what treatment we used. But for all of them, we now do, for this one, this is what you expect. For this other one, this is what you expect. For the medication that you are on, these are the side effects, and we'll follow them up for a minimum of 5 years to see. And then after that, you screen once a year to see if there's any of those side effects that we can see. We forget the psychosocial aspect of this. So again, especially if you got it as a child or as a teenager, then we also want to see what the psychosocial effect of this will be long term. So we just follow you up for a much longer time and see how you're doing in school, how you're doing with social life. Does it affect your work? All of this we follow.
And finally, Daktari, what is that one thing that you would hope people to know about childhood cancer?
Childhood cancer is not a death sentence. There is hope. I think a lot of people hear the word cancer and just think, okay, this is it. What's the point of trying? For majority of them, with treatment, there's a lot of hope. It is not the end of the world. We treat it. For a lot of them, it goes away. For some of them, it will have side effects. For some of them, we lose the battle. But if you don't try, you won't know in which category you will be. And childhood cancers do way better. I'm telling you, way better than adult cancers. Yeah, they respond much better to treatment.
Thank you so much.
You're welcome.
That has been very informative, and I hope people have learned a thing or two about it.
I hope so.
And even help in raising awareness about childhood cancer.
Yes.
That has...
Oh, can I add one thing?
Yes, yes.
So childhood, all the cancers, we need a lot of blood product support. So how other people can help, donate blood and blood products. You don't have, if you wanted to find a way to support cancer and you don't really have the financial mass, donate blood. Go and see if you're a donor, donate the blood. It goes a long way, because that is not something we buy. Someone has to donate it. Donate blood. Goes a long way to treat.
And even platelets.
Blood, platelets, FFP, the blood products. Yes. That's the appeal to you and to everyone else. So I hope I'll see you soon coming to donate blood.
Yes. I hope wamesikia, go and donate blood, because you never know, you could be saving a life of someone out there. That has been Dr. Rose Munge, who is a pediatric oncologist and head of unit at Kenyatta University Referral and Research Hospital. This conversation ends now, and this is where we put a stop to Good Morning Kenya, today being the Tuesday. We do this again tomorrow morning. Thank you for tuning in. My name is Mike. May we enjoy the rest of your viewing.